So this is another code webinar, as you see there, from SPS, and we're going to talk about the PDAC today. And the PDAC is a really interesting organization, or a really interesting contractor group, whatever you want to call them, because they have a sort of an important role, and yet the role is a little confusing, at least to my mind. And the reason I wanted to do a webinar about this is because I have heard so many strange things about the PDAC from practitioners. Most of the people who work in the front office of different practices that I talk to seem to have a good handle on what the PDAC does and what their role is and why they're important or not important. But nearly to a person, every practitioner I've talked to has a different idea of what PDAC does and why they do it and how it affects them or doesn't. So my goal here in this webinar is simply to hopefully give some clarification about the PDAC and sort of say, here's what they do, here's what they don't do, here's what it means to you as a practitioner when you're choosing a code, when you're writing your notes, when you're doing your job, right? So that's really what we're going to cover. And it is a little complicated, as anything having to do with Medicare is complicated. It's a big, complicated system. The PDAC tends to be one of those many things that we have to keep track of that can be pretty confusing. And I'm going to speak for myself only. I find it confusing. I'm not going to speak for anyone else about that, but I know that when I read about the PDAC and try to understand what its effect is on me as a practitioner, I can get a little lost in the weeds. So that's why we're going to look at it today. Okay, so let's talk about the conclusion. Right, so it's often said the best way to give a presentation is to start with the conclusion and then support it. So that's what I'm going to do. And the reason I'm going to start with the conclusion too is because I want to be clear what we're talking about and what we're not. Not using a PDAC approved code for prosthetic devices, and that's what we're going to focus on here in this webinar, is PDAC as it relates to prosthetics, not as it relates to orthotics codes. So that's a different animal that kind of functions a little differently, and we'll talk a little bit about it, but we're really focused on the prosthetic devices for this particular webinar. Not using a PDAC approved code could, the operative word here is could, right? There's a possibility that it could increase claim denial rates, complicate your appeals processes, and cause you to work harder for those when you're billing. And again, the word is could, because as with a lot of Medicare rules, Medicare and the contractors they work with have the option of exercising these rules, of applying these rules, and they have the option of not. So, so sometimes it doesn't affect you at all, and sometimes there's a possibility it affects you. So for me, it's just something that as a practitioner, I want to be aware of. I want to know, what's it mean? How's it potentially going to affect me? And then I can go back to my practice and look at what I'm doing on a day-to-day basis and audit my files internally and say, did it affect me or didn't it? How is it affecting me? The other key here that I think is so important and is often lost in all the mumbo jumbo around policy is that we as practitioners and as practices, especially smaller independent practices, it really is so important that we sit down and come up with parameters about how we're going to do things. So we understand what policy is, we understand how it works to a degree, and then we sit down and we say, this is how our practice is going to handle these situations. So in the case of the PDAC, and whether codes are approved for different items or not, you can sit down as a practice and say, this is how I interpret the policy. This is my understanding on it based on what I've read, who I've talked to at the PDAC, and you can call them, they'll talk to you, who I've talked to at Medicare or the MAC that I work with, and how our internal processes are in our own practice. That's what I'm basing my opinion on. I'm going to sit down and write up a parameter for that and say, in our practice, we are going to choose these codes for these items, or in these situations, and not these codes, or whatever. We're choosing certain products for these reasons, and certain products we're not choosing for other reasons. Whatever it is, you can write it down in your own guidelines for your practice, and that kind of structure and written document really can go a long way to support you if you do run into hassles or trouble. You can sit down and say, I didn't just willy-nilly choose this code or willy-nilly make these decisions or just pull this out of the air. I actually made a conscious decision, and I based it on research that I did. I based it on information that I gathered. That can really go a long way to show that your practice is making thoughtful decisions, and not just sort of crossing your fingers and say, well, I don't really understand it, so I'm just going to plow ahead and hope it goes really well. That's not something that's really supportive in a situation where you are trying to work on appeals or you're trying to work through audits or what have you. So that's just sort of a little bit of an aside, but it definitely is relating to the PDAC. So now let me support what I'm trying to say here. What is the PDAC? That's the bottom line here, right? It's run by Noridian, which is one of the MACs. It's the MAC for Jurisdiction D. Right, it's run by Noridian as a separate contractor for CMS. So the contract to run the PDAC through Noridian comes from CMS, and it basically says you are the entity, the PDAC is the entity with responsibility to review DME products and determine the appropriate HCPCS code for Medicare billing. Okay, that's what it says. It's right there in the policy. How you interpret that, again, that's up to you. And if your lawyer or your fellow practitioners or your business manager or whatever, as long as you're interpreting that in a consistent way, that's really helpful for any practice, right? So if a product hasn't undergone, this is straight from PDAC information right off their site. If a product has not undergone coding verification by the PDAC, it may result in denial of payments by Medicare, overpayment assessment, and or law enforcement referral by the DME MACs following a post-payment review. Whoa, wait a minute. Law enforcement. What are we talking about here? All of a sudden the PDAC in that line, in my mind, if I'm running my own little practice and I'm looking at this, I'm like, whoa, we just went from this sort of ancillary periphery organization to we're going to, throw you over to law enforcement if you don't do what we say. Wow, is it a big, huge deal, or is it, something to be aware of and not something that should rule your practice? It's hard to say. Those words are basically there, to give them the ability to follow through on any enforcement actions, right? So how do you know which one it is? One thing that's super helpful, and forgive me here, I am going to make my screen look ugly for a second so I can pull this up. Hopefully you can see this. This is a really important sheet from, in this case, Jurisdiction D, but this was a joint DME MAC publication. So this would be a very same or similar to whatever your MAC put out at this time frame around PDAC coding. And it explains how the PDAC really works and what its role is and how you can expect it to work for your practice, right? So there's this, explains that it's a joint publication, that all the MACs agree on this. It explains the background of the PDAC here, and this again is in your handouts, so I just want to point it out. And then it goes down here and it says some very important parts right here in this third section, coding guidelines for Medicare. So I want you to focus here on this paragraph where it says when a I'm sorry, let me find the right paragraph. I had it marked before. Okay, here we go. The DME MACs is this paragraph right here. The DME MACs and the Pricing, Data Analysis, and Coding Contract, or the PDAC, are responsible for assigning individual DME products, DME POS products, to the HCPCS code categories for billing Medicare. Manufacturers and other entities do not have similar authority to assign their own code determinations to specific products. Often these unofficial and unauthorized coding assignments are described as recommendations. The DME POS suppliers, that's us, right? Remember, we're called suppliers as P&O practitioners, are cautioned that such recommendations have no official status and, in the event of claim review, may result in incorrect coding, claim denial. In addition, these unofficial coding recommendations are not helpful in defense of an incorrect coded claim during the appeals process. Boom. That gives us a pretty good explanation of what's going on here and what it means to you as a practitioner. Again, when you sit down with your business managers and your front office staff and your other practitioners and you look at this, you can decide what that means to you in your practice and how that's going to affect your practice or not, what you're going to do with that. I just simply want to say that this is the authoritative document on this. This is the document that can give you the guidelines to understand what the PDAC is doing and how it affects your practice or doesn't. Because there is so much information out there that seems to be not conflicting, but at the very least confusing about what's going on with the PDAC and how it should or shouldn't affect you. So again, this document is in your handouts. It's the PDAC coding article detail there, and once you download those handouts, you'll see it. And I would encourage you to read through it. It is, I think it's only 2 pages. Yeah, it's 2 pages. It's fairly short, well worth the read, and it really can help you understand what the PDAC means for your practice or what it doesn't. One other thing I want to point out here is under the correct coding of claims bit, and I'll talk about this a little more in a second, but it talks about what to do for unreviewed products. As you know, as practitioners and front office staff, as you know, there are very few products, especially on the prosthetic side, that have actually been reviewed by PDAC and actually have PDAC recommendations. So if you look up a 5987, you'll find that there are very few feet there. Yet we know that there are plenty of feet that the manufacturers recommend for that to have that code. So it will talk about what to do when it's an unreviewed product and how you should handle that. Again, we're going to talk about that in detail in just a minute, but it's in there in that handout. So super helpful stuff. Okay, so that's what it is. That's what it means, right? Then we talk about what they do as far as coding verification. What does the PDAC do? What's the process, say, for coding verification? One place that we can look for a solid process as a comparison, and it's a loose comparison because I'm going to talk about pharma, big pharma, right? So drugs, pharmaceutical drugs, and what their process is. The reason I choose that is not because it's so similar to us in P&O, but more because they have been in trouble with the PDAC process in the past and have made corrections and have changed their processes. So I think, you know, it's a good thing to look at. Basically what happens is the manufacturer of a drug creates a product to fill a gap in a product offering or respond to a need, right? The manufacturer of that drug then vets the item. They do clinical trials, they do research, and they do focus groups often. They do other things too. Those are just some of the top things. Let me stop there and say, this is not, again, this isn't an apples to apples comparison necessarily, because do we have the option in P&O to do full-scale clinical trials and, you know, full-scale, large number of subject-type research papers, or even big focus groups, you know, across the country? Not really, because our group, you know, our patient population is so tiny compared to the patient population for, say, a depression drug, right? They have so many people that they can put into a clinical trial in so many different places in the country, and they have the ability to pull so many subjects for research that they blow us out of the water in that, right? So, you know, when we look here in a second at how we do it in P&O, we are definitely hamstrung by the fact that we have such a much smaller patient population. This coding verification process, or this process overall, is really geared toward these larger manufacturers and larger groups that produce items on a bigger scale. So that's something to keep in mind, right? After they do all these focus groups and their research and clinical trials, the manufacturer then would submit the product to PDAC for review and L code assignment, or, you know, they have their own group that handles this, right? So this is the typical process, say, that would happen. So in our case, we would submit it for PDAC review and L code assignment. The manufacturer would submit that product. The manufacturer would then get a code assignment from the PDAC and set the price at an appropriate rate for that recommendation, so that you don't have a product that costs a lot more than the code to reimburse it is for, right? Then, if all that process is followed, switching gears here to P&O process, if we did it this way exactly in P&O, the practitioner would only have to justify patient need. So then myself as a practitioner, if I choose a code that has already gone through a PDAC approval process for a device, and I put that in, and I write that up in my notes, then I'm only having to explain what the patient's K level is and what features that device has that my patient needs, why my patient needs it. So I can then cut out the whole section where I try to justify why I chose the code that I chose for that product. That's another place that we typically would go and justify, right? I say, well, my patient needs this item. My patient needs it for these functional reasons. The device does these things, based on what I can see as a professional evaluating that product. And now, if I don't have a PDAC approved code, I would then go into a big explanation as to why I chose that code and why this product fits that code and blah, blah, blah. So it's an additional place I'd have to justify. If I use a PDAC approved code, I don't have to do that, right? It just maybe makes things a little smoother. Now, is it going to change your life and make everything easier and cause you to never have to document anything? No, of course not. But it's just one more thing that you can do to smooth the road, right? To make everything go through a little smoother and a little easier. And if you can do that, great. If we don't have coding verification, what happens, right? So what we often see happening in P&O is the manufacturer will create the product. The manufacturer vets the item, but again, for lots of reasons, it's hard to do large-scale research and what have you. So they might try it on a user, have a few customers try it on a few patients, do some sort of informal vetting. Then they would potentially pick an L code that gets a high reimbursement. This is what we've seen happen in the past pretty often, where manufacturers will sometimes choose a code that has this really high reimbursement, and they will often build the product to fit the code so that it does have the features or the characteristics. However, not always, and it's something that we have to be aware of. Again, if we as practitioners are aware of this system and how it works, then we can make an informed decision as to whether we think that product fits that code or doesn't. So if I'm looking at a code that a manufacturer has recommended for a product, and I look at the product, and based on the information I've gotten from the manufacturer and what I see of the product and questions I've asked, I've decided it doesn't fit that code, then at least I'm making that informed decision. I'm not taking a recommendation just right off the list without thinking about it. Maybe I do agree that it fits that code. Great. And I can justify and defend that. Excellent. But we just want to make informed decisions. We don't want to just take what we're fed, right? Necessarily. Then if the product, if they've chosen a reimbursement code or a code that reimburses high for high dollar amount, then they often will price that product according to that recommendation. So if you've got, again, a product that is recommended for a certain code, the price of the product is in line with that higher code. But then that manufacturer, if they went to PDAC after that and PDAC gave them a different coding recommendation that didn't reimburse as high, they have the potential to have a product that is, selling at a price that's at or above the reimbursement, which obviously is not good for anybody. So, and doesn't make business sense, right? So if this process happens, what we've seen in the past happens, where the manufacturer does not go to PDAC and does not get that item approved through PDAC for a certain code, then we as practitioners have the burden of explaining and justifying that code choice with every product. So if I fit Molly's Fantastic Foot that Molly, the manufacturer, has created on patient A, and I did that, Molly's Fantastic Foot has not been put through the PDAC process and does not have a PDAC approved code for it, then I as a practitioner have to go through and say, here's why this patient A needed it, here's what it does, and this is why I chose that code for this product, because this product has all these characteristics, and I can explain that and prove it and blah, blah, blah. Now I've got extra things I have to justify. Then I go back and I do the same thing for patient B. I want that same foot, Molly's fantastic foot on patient B, and I can't say, well, it's just the same recommendation as patient A. I chose that code for that foot because of everything I said before. Doesn't work. I have to say it all over again on patient B. Go to patient C, I want to put the same foot. I'll have to say it all over again on patient C. Every time I have to restate that, every time I have to justify that product code, which just adds to, you know, the paperwork that I'm having to do, adds to the things that I have to keep track of as a practitioner. We have a question here. If the manufacturer is using the AOPA testing guidelines, I would think they would have an argument to make on the product selected. Thank you for bringing that up. That's a great point, and we're going there next. We're definitely going to talk about the AOPA foot coding or foot project and how that relates to this. So hold that thought. I think I'm going to answer it in the next slide here, but thank you. So moving on to that then, let's talk about that. Let's discuss the AOPA foot project. It's like I paid that person for a transition there. Thank you. Anyway, I didn't, I promise. What is the AOPA foot project? So just so I don't have too rocky a transition there, if we have a foot, just to reiterate on the no coding verification or an item, any device, knee, foot, whatever, that doesn't go through the PDAC coding process, then we as practitioners need to justify code choice for those products. That's fine, it can be done. It's absolutely doable. We do it all the time, but we need to make sure we consistently do it, right? A lot of times the manufacturer will say, well, we didn't go through PDAC coding approval, but we did subject this in this case a foot, if we're using an AOPA foot project, obviously, we did subject this foot to some testing based on the AOPA foot project. If you'll recall, and again, I'm going to make my screen ugly for a second here so I can pull this up. If you'll recall, a few years ago, AOPA had the prosthetic foot project that came out. Right here on the front page of the prosthetic foot project is what it is not, and what patient care facilities and practitioners need to know. Right here, it explains it all. Encourage you to look this over to really understand what the foot project is, because so often manufacturers will say, you know, we tested it to the AOPA foot project standards and it passed those tests flying colors, therefore we think it should be coded like this, and they'll give a coding recommendation based on that. Understand what this project was and wasn't, understand how it works and what it means, and understand the difference between that and PDAC. That's what we want to get a handle on right now. So here it is. You can read it. It's in your handouts, okay? And I'm going to pull some information out of it here on the slides, but it's in your handouts. Highly recommend you look it over. It can be really helpful. But talking about it here, it's a good testing guide, right? It wasn't a proposal to CMS to adopt a foot testing procedure so that certain features of different feet could be validated. So they could say, yes, this foot actually does have multi-axial motion. We can show that because we actually tested it and showed that it's moving in a multi-axial fashion in a certain parameter, right? Great. And that's a good testing guideline, and it's good information to have. What it is not is a sole recommendation, you know, a sole justification for a recommendation of a code. If I have a product that the manufacturer says absolutely moves, you know, certain degrees of movement and therefore qualifies for multi-axial, that's great and that's good information. But is that the only thing that I would need to justify choosing a code? No, I still have to use my clinical knowledge. I still have to use my clinical reasoning. I still have to put my practitioner knowledge onto that coding recommendation and consider why I chose it and explain why I chose whatever code it was. So it's one support. It's not the only support, and it's not a proxy or in lieu of getting PDAC approval. Having a PDAC approval for a code on a product is wholly different than having the product pass the AOPA foot test or be or have AOPA recommended codes. They are two different animals. One could support the other, but PDAC is the final authority when you're talking about Medicare billing. Okay, and Medicare billing guidelines are often followed by other insurers, so that's something to keep in mind. Notice that it says in the foot project too, unless the recommendations are adopted and published by CMS through the PDAC, your choice of appropriate coding for prosthetic feet remains your decision and responsibility. It says that right there. Nobody's trying to hide that, okay? So it's all right there, black and white. And the thing is, what we know happened is CMS did not adopt these recommendations. So back in the day, in case you don't remember or you weren't around at this point, in P&O, basically CMS decided one day, they woke up one day on a Tuesday, you know how it is, and they said, you know what, we don't need all these foot codes, we're going to have just 4 foot codes, that's enough. And of course, AOPA and all the rest of our organizations mobilized and fought against that and said, wait a minute, if you're going to change all the foot codes, at least give us a say in it too. And they put together this amazing project. They brought manufacturers together. They made testing guidelines, very complex, really big project. They submitted it to CMS and said, okay, here, if you're going to change foot codes, at least use these sorts of parameters or let us have some input into that. And CMS said, thank you very much for turning those into us. Oops. Administration change, forget the whole thing, we're not talking about it anymore, end of story. It was crazy. They put a lot of work into this, a lot of detail. They came up with some great guidelines, and then through transitions and you know, different administrations and crazy stuff that went on, the whole thing pretty much got dropped. Does that mean these aren't great testing guidelines? Of course they are. They're really great. But CMS did not adopt them through the PDAC. Therefore, it is not a final say for a coding decision. That's all. So that's just something to help keep straight, because you see that all the time. So let's use it. Let's do an example here, because you know, in keeping all this straight, it might be confusing. So here's an example of a code that is often, there's often a lot of confusion around. Again, I'm speaking for myself. I am often confused by the code 5986 and what is appropriate or what isn't appropriate to bill under that. And that's important because I, as a practitioner, am the final say. If I'm in my own practice today and I don't understand what this means, or I haven't made a decision, that's a problem. I have to sit down as a practitioner and say, okay, based on my research, this is what I've decided. And then we are going to follow that. We as a practice, or me at least as a practitioner, I'm going to follow that my whole, you know, for the rest of my time as a practitioner. I'm going to use that opinion and go with it. That shows a consistency and a thoughtfulness of you know, the choice that you made. And that's important for you as a practice. That supports your decisions as a practice, to have thoughtfulness and guidelines that you follow, etc., based on something, right? Again, that's a tangent. If we look at the example 5986, a multi-axial rotation unit, that's the wording in the code, unit, and it says MCP or equal. I don't know about you, never heard of an MCP, okay? There might be some, actually, I've even asked some older practitioners that I know, and they could scarcely remember what the MCP is. So what I see as a code is that it says multi-axial rotation unit, meaning it's a separate unit, right? It doesn't describe here anything saying that you have to have a certain amount of movement, or the movement has to come from a certain area, or the movement has to whatever. It doesn't say anything about the movement capabilities. It says that it's multi-axial. I'm sorry, it doesn't give detail about the movement. It does say something about the movement because it says multi-axial. Multi-axial rotation unit, a unit that you put on a foot that has multi-axial rotation capability and provides that to the foot, right? That's how I read it. If you read it differently, cool beans, and that's totally up to you. That's what is so great about this system right now, is that we as practitioners still have the final say. We as practitioners are the ones that decide what the code will be, because we have thought about it and we've made that decision and we can back it up. Okay, so you make your decision. I would say that that's a unit, it's separate, whatever. Okay, then we look at the AOPA coding, the AOPA foot project information, and it says to be considered multi-axial, you have to have dorsiflexion of 10 degrees, plantar flexion of 8, inversion of 8 under a certain amount of load, right? And you can look it up in the foot project there as to what numbers those are exactly. That would qualify as multi-axial movement. Super duper. That is totally separate from this, right? So if I say that my foot has dorsiflexion of 10 degrees, plantar flexion of 8, inversion of 8 under a certain load, that's super. It's got multi-axial. Is it a unit, a multi-axial rotation unit separate from the foot? I don't know. Maybe it is, maybe it isn't. And, so to justify the code choice based on how much movement the item gets is not helpful in this case. What we would need to do is look at what the original code was based on. The original 5986 code, it says right in the code, says that it's for an MCP or equal. The MCP unit is shown here, at least what we think is the MCP unit, right? It is the MCP unit here. Is shown here in the original patent as a separate unit that attaches to a satch foot, stuck on top of the satch foot, that provides movement that the satch foot couldn't provide, is a separate unit. Okay, so if that's what we're doing, if we're using the original code language and what it was meant to look at, that's what it's meant to look at. It's right there. Okay, and so if I go in and I justify a foot that doesn't have a separate unit, but I say it has all this movement, that's apples to apples, that's apples to oranges. We're not justifying the right thing in that case, right? Now, do we disagree here? Do we say as a P&O, as a field, that do we disagree with what this language is saying? Do I, as a practitioner, say, you know what, I have seen lots of new materials, new feet, new ways of handling this idea that we need multi-axial motion besides strapping a separate unit on top of a foot that's less than, right? There are better ways to do this. There are feet that have that movement in the foot. I don't have to put a separate unit on top, and that's great. So new materials, in this case, have probably outpaced old coding rules. Does that mean that as a practice, I get to say, or as a practitioner, I'm going to say, well, because the new materials do all this, I know your code says one thing, but I've decided that I'm going to code it a different way. Again, totally up to you. If you feel like you can justify that and you want to do that, and that's your belief that you don't have to have a separate unit to qualify for that code, and you think that movement happens in the foot and that's good enough, awesome. Do that. Go for it. What I'm saying is that in our current system, PDAC has told us that they are the ones for Medicare that are going to choose which code goes to what. And they have shown in, from past coding decisions that they feel like it's a separate unit. I don't agree with that necessarily, that that's the best way to go. It's probably a better way to go to have it integrated into the foot. But again, that's a separate argument. I'm barking up the wrong tree at that point, right? So what's the safest thing to do? I'm sitting in my own little practice right now. I want to be super safe. I'm going to look at PDAC coded items and say, okay, I'm going to use a PDAC coding recommendation for a certain product to qualify for that code and have the safest outcome. It does not mean that I don't have the option to use those codes in a different way and support it clearly and defend my decision. I absolutely can do that. That's the beauty of the system. I can do that. I have that option. I just want to do it going in with the knowledge that I've made that conscious decision, not, oh, I don't really get PDAC, I'm not really paying attention, so I'm just going to do it the way I did it before and tra-la-la. That's going to be really hard to defend in an audit, right? Whereas if I made a conscious decision and had a set of background guidelines behind it, that's going to be a lot easier to defend. So I know this is a little opaque. I know this is a little confusing because with these kind of rules and guidelines, you can't be super black and white. And again, I would argue that the gray area can be a benefit instead of a pain in the neck only, right? It is a bit of a pain in the neck. It'd be nice to know exactly what we should and shouldn't do. But again, if we are told exactly what to do in a very black and white way, then it takes away our choice as practitioners. It takes away our ability to make clinical decisions based on our knowledge set and defend those decisions. So maybe gray isn't always so bad. For this kind of thing, it's a little hard. It's hard to understand, what the decisions are. But again, this is why I give you these handouts. This is why I say read up on it, understand it, and make your decisions instead of just taking what's given, right? So then you might say, well, okay, I use manufacturer recommended codes all the time, no matter what. I still get paid. Everything's great. Sure, I have denials, but they're not necessarily for this, right? Well, that's true. It's not always a clear denial, and it's not always an instant denial as to why it might get denied. So you may have 10 denials for different things, and possibly 5 of those are because you didn't choose a PDAC approved product, or you used a product without a PDAC code approved for it. Or 3 of those could be. It's really hard to tell. But if you can decrease the number of ways that you can end up in a denial and an audit, then great. Here's one way you could potentially decrease it, right? Someone's asking, what percentage of current componentry would you say have a PDAC letter attached to product? So my understanding on prosthetics, and I believe, I can't verify where this number comes from, what I've heard is 15% of prosthetic componentry would have a PDAC approved code, and I would say that's a little generous. I'm not 15% sounds high to me. That's what I've heard, but the fact is there are very few, very, very few. So again, this is a webinar about understanding what the parameters are and understanding what you need to do to keep abreast of this stuff. But it's not like you could go out tomorrow and say, okay, I'm only going to use PDAC approved products just to be super safe, because you would be limiting yourself to 5 feet and 3 knees or something crazy like that. So you can't do that tomorrow, but you can be aware of the situation and make sure that you have a process in place to make clear decisions about it as we wait to have more and more products being PDAC approved. And then someone says, are you aware of any audits that have been on prosthetics for PDAC letter? I think you mean basically audits or denials because the practitioner did not choose a PDAC approved code, PDAC approved coded item. And if that's what you mean, then yes, it does absolutely happen. Do I have exact numbers? No, that's the problem, because it usually will come up later in the appeals process. So you absolutely can get denied for that, or what would happen is you would put through a claim. You wouldn't necessarily have supported why you chose the code that you chose for that foot clearly enough. You could get a denial for that. It wouldn't be super clear that's what the denial was for. It comes up in audit or appeal, and you say, well, I chose it for this reason. Oh, okay, now it's clear that it was originally denied because you didn't have the PDAC approved item. So it is not a requirement that prosthetics, that most prosthetic codes are not required to have a PDAC approved product, unlike orthotics, right? So in orthotics, there are several segments, like spinal is a good example, where you are required to use PDAC approved products for each of those codes, right? They have to be listed under PDAC to use them. That's a requirement. That's an instant denial if you don't do it, right? And that's a road you don't want to go down. In prosthetics, it's not a requirement. It's absolutely, encouraged, and it's definitely something that that PDAC, again, as we read in that front page, makes clear that they have the ability to deny based on that, but it's not a requirement. So if you can prove that you chose it for a good reason and you explain it well and defend it well, you could still get paid, right? Hopefully that makes sense. But because it's not a requirement, it leaves that gray area. And the gray area, again, can be good or bad. It's good if you understand it and you're making conscious decisions. It's bad if you're floating around out there and you don't know why you've done what you did. So on the I still get paid, even though that kind of flows into this, right? It's bottom line is it's going to be easier to defend product and code choice if you have PDAC approved products and codes, right? And more and more commercial payers, including like Travelers for work comp, those kind of places, are following PDAC recommendations and guidelines. And of course, we know a lot of payers follow Medicare guidelines in general. So it's not just it's not just going to affect Medicare. You have to think about what it's going to do to your other payers as well. Again, this isn't something that I would say should take over your whole life, right? This is just one piece of a puzzle where you can help yourself and you can make good decisions and make decisions in a knowledgeable way, and that's it, right? It doesn't have to be that you change everything you do in your practice around this. Someone saying, I'm guessing defending my choice by the manufacturer's product testing and recommendations will not be enough. Again, I would say if you agree, if you read through product recommendations, product testing from the manufacturer, and you say, yes, I see right here, that makes perfect sense to me. I see right here that what you're saying is happening is actually happening in that foot. I believe that. I can defend that. And I can say that based on my professional opinion, that code does fit that product, absolutely, and I'm ready to defend that to, to a payer. Then yes, that is enough. That's enough, right? If you're just taking that coding recommendation and not thinking about it, putting it through, and then you're back on audit later, you get questioned and you go, why did I choose that code? Again, I would say, what if they question you on the code for the ankle, right? What if they come back to you and say, well, you chose a 5986 code for a foot that had an integrated multi-axial rotation and movement in it, not a separate unit on top. What if Medicare were to say to you, well, why did you choose that when it clearly says unit and you should have a separate unit? Are you going to be able to defend that? Do you feel comfortable saying, I chose that because although that says unit, I believe that these components in the foot are acting in the same way, and therefore it's separate, and it does the same thing, and I'm defending that. If you're good with that, go to town, go for it. Just don't. I'm just saying, don't do it without knowing what you're arguing, right? So, hi Molly. Quickly back to orthotic PDAC requirements. You stated all spinal must use PDAC approved products. My understanding is that knee products also require PDAC approval. Is that correct? Yeah, there's a whole list of different orthotics codes that require PDAC approval, and let me just pull that up real quick. So we have here is an explanation of how you can find that list, right? So if you haven't been to the PDAC site, definitely go check it out. And this handout tells you how to work through that site and how to use it. It's not the most user-friendly, but it's not too bad. So highly recommend you do that. That will help you see which codes require it and which don't. And also I've put in there, not that one, not that one. We looked at that one, sorry. Not that, okay, the last one. Okay. Also, you have information from AOPA that tells you where the codes are. Oh, maybe I didn't put it in here. Ah, here we go. I'm sorry. It's in the handout with the correct coding recommendation. It will actually show you on the PDAC website again where you can pull up what codes exactly require PDAC approval and which don't. And you're right, it's not just spinal. There are several. There's actually one prosthetic code too that requires PDAC approval. It's for the powered ankle. And then there are a bunch of spinal. There are actually a couple AFO codes and knees as well. So you have to check that and look at each code individually. AOPA on their website also has a list of them, which is super helpful. So definitely recommend checking out the AOPA website that will line that out. Thanks for that question. So, okay. So let me just go back to make sure. Okay, so we looked at that. So this, again, perfect question. This kind of brings up what that last question just said. PDAC codes are required on certain items. Mostly they're orthotics items. There's one prosthetic item it's required on. You can check it out on the PDAC website. Again, that handout kind of helps you understand where to go to get that information. PDAC approved codes are not required for most prosthetic codes. They're not a requirement. But again, anytime Medicare has a recommendation or a ruling and they don't require it, doesn't mean that it's not harmful for you to not follow their recommendation, right? Just because it's not required doesn't mean you can ignore it and still be safe on coding. So just be aware of it. Don't say, well, it's not required, so I'm not even going to look at it. That's where you get into trouble potentially, right? Oh, and someone, thank you, MCP, someone says Medical Center Prosthetics, Inc. Good to know. So there is someone who was around back with when the MCP ankle or MCP unit came out. Thank you for that. Appreciate it. I do not remember that. I've been in P&O for over 20 years, and I totally, when I saw MCP, I thought, okay, never heard of it, never saw it before, but that's good to know, so thank you. Back to this slide too. Practitioners still have the final responsibility, of course. Again, that's the beauty of it. We can still make the decision. If you have an item that doesn't have a PDAC approved code assigned to it, that doesn't mean you don't use the item. It just means you make a conscious decision that you can defend on why you chose whatever code you chose. If you choose one that does have a PDAC approved code, you don't have to go through that. That's it. It saves you a little step right there. It saves you a little time potentially. That's all. But it doesn't mean you don't use those unapproved ones, because again, if you went through and looked at what is approved for PDAC coding and what isn't, you'd notice that you have basically almost zero choice of products to use on your patients, which isn't practical. So to keep that in mind. We just want to make sure, again, if I haven't beat this dead horse enough, we are making sure that we're making a conscious choice, not just willy-nilly following the whims of whatever someone tells us. So again, CMS and the MAC have guidance on pricing versus coding. Okay, so price and fees are not part of correct coding. Electing a code based upon the fee schedule will almost always result in an incorrect coding determination. So that's a good message to understand. If you have a product and you're looking at it and you're saying, I really want to use this product, but I believe it should be under this code, A code, right? And the manufacturer is recommending B code, but the item costs me as much as A code would reimburse, then you have a real tough decision to make there, right? Because you can't use the fact that reimbursement would be too low to make a decision on the coding. They don't go together, and if you do that, you are running the risk of having an incorrect coding determination and denial, right? So that's where we as practitioners are a little bit in a pickle. We have to look at that item, decide what code fits the item, and then look at the reimbursement and make a business decision. And those are two different things. A business decision instead versus a coding decision should be two different things, right? And then, of course, they go on to say there the HCPCS codes describe the product, not the price. The price shouldn't come into it. It has to, for most of us who have small businesses, it has to be part of it. But again, it should be a separate investigation for you. So the conclusion again, not using PDAC approved codes for prosthetic devices or not using prosthetic items that have PDAC approved codes assigned to them could, again, the operative word is could, increase claim denial rates, complicate your appeals, or cause you to work harder. It could do that. It won't always, and it's going to be worse for some than others because it really depends often on your standing with CMS, how well you've done in audits, you know, what your provider error rate is, those kind of things that, you know, we've talked on these webinars about before. So if you're in a rocky situation anyway and you're trying to do everything under the sun to keep things smooth and to do things as safe as possible, then one of the tools in your toolbox might be to look for products that have the PDAC approved codes already. Or at least if you pick one that doesn't, to understand that you need to justify your code choice along with justifying the features for the patient, why the patient needs it, K-level, etc. That's it, just to have that kind of base knowledge. So there are some references here, and you know these sites. I'm not telling you anything new here. Obviously, AOPA is very helpful. The DME PDAC that's in that handout, that's a part of your handout group there, as far as how to look that up. And I would say, like most of us who are working in a front office probably already go to that site pretty frequently. But if you're a practitioner and you haven't been to that site or looked at it, I would encourage you to go check it out because there's going to be some information in there that'd be super helpful for you as a practitioner and help you make good clinical decisions based on that. And then, of course, that last reference is the letter that I already showed you earlier. You have questions, you have comments, you have feedback, that would all be great. I appreciate people asking questions as we go. That's my contact information. Please call and let me know what you think or how we can improve. There's also at the end of this, you're going to get a survey asking what you thought of the webinar, what we can improve or improve next time. These are, this one is particularly fraught with difficulty as far as getting the information out in a clear way. Again, that's why I say read through those handouts and do the research yourself and come to your own conclusions, because we have to be sort of vague on these, because it really is a matter of choice here for as a practitioner. So even more important this time that we get your feedback if at all possible. If you can let us know, was this helpful, was it not, and how could we do it better next time, if there is a next time on that one. So you'll also get the test in a separate email, probably tomorrow or the day after that. That test has instructions on where to submit it so you can get the ABC credits that have been applied for. So be looking for that. And I think that's it. We have like a few minutes, 3 or 4 minutes for questions. If anybody had a question they did not want to type but would like to ask verbally, now would be the time to sort of put up the little digital hand if you want, and I will unmute you so you can verbally ask the question. I'll give you just a couple seconds for that, or a couple minutes here. And of course, you can always still type in the question as well if you like. Okay. Okay, so seeing no questions at this point, I will go ahead and end the webinar. Again, it'll be recorded and you can find that on the SPS website. And we look forward to seeing you at the next webinar Wednesday in about 4 weeks, and hopefully have some helpful information for you there too. Great. Thank you for attending, everyone.